Hello, this is your brain on drugs, and this is a punk rock psychiatrist. Today, we are going to continue with medications for obesity. And last time we talked about the stimulant medications, um, mostly phentermine, and then kind of other stimulant medications. Today, we're going to continue with these medications, and we've got a lot left. There's actually quite a few before we get to GLP-1s. I don't know if I'm going to get through all of them today or not, but we'll go ahead and get started. And the first one is Qsymia, otherwise known as Phentermine Topiramate ER, because it's a combo pill of phentermine, which we've already discussed, and Topiramate ER, which is a medication that most physicians out there are going to be familiar with. This medication came out in 2012. And so, how does it work? Well, we already know how phentermine works: norepinephrine releasing agent causing appetite suppression. We throw the topiramate ER extended release on there. It's a carbonic anhydrase inhibitor, which can lead to satiety, which means that you feel full, um, or satisfied. You feel satisfied, you can stop eating. It can help with sugar craving, and that is often because it causes an adverse taste. When you eat certain foods, you might be like, I don't like the taste," so then you don't want to eat it. And I think it's particularly good for night eating. So we'll talk about that in a second. All right. So this is another one of the FDA approved treatments. So this is FDA approved, and it's for chronic weight loss. If you remember, phentermine was only approved for short term, which is like 3 months. This contains phentermine, but it's for chronic. But they you remember how I said I don't mind using phentermine chronic if it's working for the patient, they're not having side effects, etc. But it's not FDA approved for it, and there's some states that um, really won't let you use it, so you have to take like a month break before you get started again. Well, with this one, you don't have that issue, and it can be used for those ages 12 and up. Now, you may be wondering, why is this? Um, I don't know, because the FDA is silly. Partly, it's probably because the dose is a little bit less, but the max dose of this is actually about the same. I think it was just because it was tested for it, and phentermine wasn't. And phentermine came out in like 1959, and so no one like asked the FDA to change it because no one's making any money off of it. And that's why I say, look, here's even more evidence that giving phentermine long term is fine, because here's a medication that contains phentermine that can be used long term. All right. One good thing about Qsymia is that it became generic in May 2025. So it is essentially our next to phentermine. This is our next product that has become generic, and that was just a year ago. So many of you may not know that. So that means it's probably become more affordable. Sometimes when things go generic, they actually don't become as, like, some of them drop ridiculously, like $5 a pill down to like 4 cents, or more often than not $1 per pill down to, like, 5 to 10 cents. But sometimes it'll be like $4 or $5 down to like $3. So it's like less, but it's still expensive. So it's a good thing when things become generic. So this medication is generic now. Average weight loss is 10%. So that is the highest that we have discussed as of yet. And it is actually the highest weight loss other than the GLP-1s. So if a GLP-1 is not a good option for a patient, doesn't work out, can't pay for it, whatever, this would be my second choice, the Qsymia. So this is the next most weight loss next to the GLP-1s. Let's talk about how we dose this guy. So it's a little bit complicated, timing of the doses. So the instructions say, so the first pill is a 3.75 milligram phentermine containing 23 milligram containing topiramate, which to me is like really tiny, because the starting dose of phentermine is 15, and this is only 3.75. The starting dose of topiramate is 25, so 23, that's pretty, um, about this, it's about the same. So in the morning for 2 weeks, then you go up to the double that size, 7.5, 46 for 12 weeks. And so it's like a kind of an automatic, after 2 weeks, you go up to the second pill for 3 months. And then you're not supposed to increase the dose for like 3 months. And if they haven't had at least a 3% weight loss, you can either say, I'm giving up on this, let's try something else, and say, we'll move on to the GLP-1s, because often this is one of the meds you have to go through to get to a GLP-1 for the insurance to cover it. And then, so you could either say, okay, not going to work, or you could say, we have higher doses available. Let's go ahead and give it higher dose, increase to the 11.2569 for 2 weeks, and then go up to the 1592. All right. I find this cumbersome. I find the whole Qsymia situation cumbersome. Like, there's just, and there's more prescribing complications. There's the RIMS requirement, which we'll talk about in a second. And it, now that it's generic, it's a little bit cheaper, but like, you just prescribe them separately, right? So you can, like, I would pretty much always prescribe them separately. I don't know when and why I would ever want to like give someone straight up like, well, what's now not Qsymia is just generic Phentermine, Topiramate, ER. And there's several reasons, not just like for saving money. There's like actually several reasons. So remember how I said Topiramate was good for night eating? And it's also like Topiramate's sedating. And like, why do I, and Phentermine is weight promoting. Why do I want to dose these at the same time? Like, if I'm at a lower dose, and also Topiramate causes like cognitive dysfunction. uh, Topiramate's used a lot in psychiatry for like weight gain for antipsychotics. It's been used for a long time, or to, just counteracting weight gain from medications that we prescribe. It's used in migraines, so it's a pretty common medication, and I don't really like it because of like, people, they feel like their thinking is slowed down when they take it. And so I'm not a huge fan because of that. The Phentermine I like, the Topiramate I'm not a huge fan of, but like, if I'm going to dose Topiramate, I want it at night. So that sedation and that cognitive dysfunction is loaded when the patient's sleeping and not during the day. All right. And it also helps with that night eating, right? You're not going to get that night eating benefit as much if you take it in the morning. So, big benefit to dosing separately is you can dose them at different times. And you can also have started Phentermine, because usually for insurance coverages, I don't know about anymore now that we have a generic, but like, typically you have to start Phentermine first anyway. So the patient's already on Phentermine and they're taking Phentermine in the morning, and we're already giving them 15 to 30 milligrams. They're already on this, right? We've you're going to go with Phentermine first anyway, right? Why would you start two meds at the same time? Okay. So start Phentermine, see how they do with Phentermine. If Phentermine's adequate, then keep it. Okay. Um, if not, then add Topiramate at night, 25 milligrams, and you can titrate up to 100. They make it these weird dosings like 23, 46, 69, 92. They do that just so they can say, well, it's not 25, 50, 75, 100. That's not what it was tested at, so you can't do it. It's like, come on, man. Like, they do this on purpose. This is a money-making scam. They make the doses so that they don't match up exactly with what they're available separately. But there is no reason why you can't. That's just to scare doctors into thinking, oh, I can't do that because it's not the same, and that's not what it was tested at. So like, we don't know what's going to happen. I don't want to take on the risk. And it's like, stop being a baby. Okay, like, it's the same. And you're saving money and you're dosing it at different times of day. And like, I've heard several obesity specialists that are way more specialized and seeing way more patients than I have, and they all recommend doing this. So don't freak out about it. All right. So, advantages: it's cheaper to dose it separately. You don't have to deal with prior authorization for insurance coverage purposes, because these are both two very old, cheap drugs. There's no RIMS requirement. I'm going to talk about RIMS in a second. And you can do the AM PM dosing, which could be better tolerated. It's just better to dose them separately in general. Like, even if I had access to Qsymia and it costs nothing, I would still want to dose it separately to get around the other hurdles. Okay, let's talk about RIMS. All right, many of you may not know what RIMS is. It's a program where there's certain drugs that basically the FDA has determined are extra dangerous, This is like almost beyond black box warnings, and we need to do something. Like in clozapine, the RIMS is gone, but the RIMS for clozapine used to be you have to get like a white count, neutrophil count on certain time schedules before the med can be dispensed. You still need to do that, but you don't have to, you can manage it how you want to. You don't have to follow the RIMS schedule. All right. And you don't have to like be registered with RIMS and you used to have to like be registered with RIMS and input the neutrophil count into RIMS into this system. It was very cumbersome. And in Europe, they haven't been doing this for years because we know that you don't need to get the ANC forever with clozapine, and RIMS required that. And now RIMS is gone. You still need to, be safe. You still have to get the lab, but like, you don't have to deal with the RIMS cumbersome process. And the other thing is like, not every pharmacy a pharmacy has to be specifically certified in RIMS for that drug. So when Qsymia was out like a while back, there were a lot of pharmacies that were just like, we don't carry it because we don't want to deal with the RIMS. And so like that was another issue. And so what, so you're probably asking yourself, like, what is dangerous about this med that requires this RIM, and what is the requirement? Because every RIMS requirement's different. Like with clozapine, it was, check this lab, put it in, etc. So let's talk about what Qsymia's was, or is, it still is. So the requirement is due to it has a teratogenic risk. It can cause, which is birth defects. It can cause orofacial clefts. So essentially, it can cause like a cleft lip or cleft palate, right? Orofacial, so mouth and face clefts. So like, you know, what used to be, the old term was hair lip. So whatever you guys know it as, cleft palate, cleft lip, right? It's where where that little ridges, those two little ridges on your upper lip that are below your nose, um, your face, like when you're a fetus, your face wraps around and seals together in the front, and those lines are like where it seals, and it seals all the way back down your throat. And some people that doesn't close, and then they have a gap there, and we have to do surgery, and there can be complications with hearing can be affected, your nasal passages and so forth can be affected. It can affect your voice. You have this scar. um, Many countries, they don't do these surgeries, so people are just left like this, and they can be treated differently because they look different than other people. So obviously we don't want to give people this risk. And so the RIMS is basically to warn the patient about this. That's it. Just warn them. And for whatever reason, the RIMS requirement exists for men as well. There is no risk for a man taking this for their offspring to get this, but for whatever reason, the RIMS requirement exists for both. As far as I could tell, I maybe that's changed, but like I thought that was kind of silly. I used to have that in my slides, but I removed it. Maybe I looked it up and it was like, oh no, it's not for men, but I'm pretty sure it is. So what is the risk? So relative risk 9.6, that means it's a 9.6 times increased relative risk, and odds ratio is 1.47 to 5.32. So up to 5 times increased odds. And relative risk and odds ratio are sort of similar, but some, it depends on kind of how the study was done, which one's more useful. But they've done different studies, and those were the risks that came up. On 2/3 of the studies, there were no significant increase. So they actually didn't find anything on 2/3 of the studies. I mean, those numbers sound kind of high, 1.47 is not much increased risk, but 5.36 is, 9.6, that's a lot. But like when almost no one is getting this, any increased risk is going to show up as a big number, right? So if it's something common and you have a big relative risk, that's big deal, right? Like if 10% of people get it and there's a 6 times increased risk, I mean, that's like 60%, right? So like that's massive. But if it's like 0.00001% risk and now it's 0.0006% risk, that's pretty much nothing, right? So you have to take it into that concept. What's the absolute versus relative You really have to look at the numbers, and the risk is pretty low. I mean, as evidenced by 2/3 of the studies didn't even find anything, right? So that's basically all you have to do is just tell them about it. And so if you prescribe them separately, once again, we don't have to deal with this. But I would still counsel the patient. You know, um, they recommend getting a pregnancy test, but it's not required. Um, so, I mean, the thing is, none of these medications for weight loss that are FDA approved for weight loss are approved in pregnant women. This one specifically, we have information that there is a risk in pregnancy. The rest of them is kind of like, we don't know, don't deal with it. And I mean, do we really want to be treating obesity in women that are supposed to be gaining weight? You know, we don't want them to gain too much weight, but we don't want them not to gain weight and then their baby not to get the nutrition that it needs. So generally, we don't use these in pregnant women either. But this one, you have to be worried at early developmental, like the woman doesn't know she's pregnant yet. That's why, you know, it might be a good thing to get the pregnancy test. Contraception is recommended but not required. There are medications such as what is it, the retin-A, I forget, the Accutane, right? You have to use two forms, and you have to like sign something that say, I'm going to use birth control. And even if you're not sexually active, you have to use birth control. Okay, like on this one, you say you should use birth control, but it's not like a you have to, or I'm not giving you this med, and you know your RIMS is not approved or whatever. Okay, so the risk is low, but it exists. Um, the pharmacy has to be certified, not available to all pharmacies. The RIMS is tied to topiramate specifically, not to phentermine. So if you're giving phentermine on its own, don't need to worry about this at all. Interestingly, topiramate is, you know, topiramate by itself not approved for weight loss. Topiramate combined with phentermine is the one that is approved for weight loss. And topiramate by itself is approved for migraine prophylaxis, so prevention of migraines, and it's approved for seizures. Interestingly, no RIMS requirement when you give topiramate for those things. This is like one of those situations where the FDA has decided weight loss is less important than treating seizures and migraines, so we're going to put the warning on it for weight loss, but not for these other things. That just kind of speaks to me that like the risk is like, if the risk was really, really severe, they would have it on everything for topiramate. And in fact, for the most part, you're taking lower doses. I mean, look, um, you're taking maybe only 46 milligrams. Typically, for other conditions, you're taking much more than that, over 100. Okay. I mean, this maxes out at 92. So I don't know. It's one of those things where they're like, oh, we don't really need to treat weight loss. We don't really take it that seriously, even though it is the number one chronic disease in the United States. Oh, we're not going to take it that seriously. So we're going to have more warnings on the same drug that there aren't the warnings on. Now, there are warnings on it for the other purposes to say, hey, you shouldn't get pregnant on this, but they don't have the RIMS requirement. Okay, so like the warning is not as severe. Like there's certain things where they have like the old X warning for pregnancy. Um, they would use X for some indications, but they'd use a D for other indications where the X is like the worst. And it was just interesting to me, like, oh, it's X for um, I think valproate is X for like migraines, but it's D for bipolar disorder. Because it's like, oh well, treating bipolar disorder is more important than treating migraines, so we're gonna have like a less severe warning on bipolar or something. And I'm like, you should not be using valproate in bipolar disorder in a pregnant patient ever. It should be an X as well. So I don't know. This is my opinion, and you know these people should be like smarter and more thoughtful than me, but like politics comes into play, and you know also inertia, where like this is how we used to do it and we just haven't changed it, and we don't feel like changing it, and we're lazy about it. And so you have to like kind of read through the literature and make your own opinion, because the FDA is not always like the best gauge. Okay, so but definitely when they're warning, you got to take it seriously, because like you can't just be like, oh, screw the FDA. I don't care. They're a bunch of morons. I'm not going to listen to this at all. I'm not going to tell the patient about this. Well, then when something bad happens, you're going to get really screwed because there's an FDA warning on this and you should have freaking said something about it. So we take it seriously in that we say something about it, but that doesn't mean we don't do it. Okay. So adverse effects, we already know phentermine's adverse effects: cardiovascular stuff, heart rate, blood pressure, difficulty sleeping, anxiety. Topiramate, cognitive dysfunction, I mentioned. Paresthesias also, so that's like numbness and tingling in the extremities. Nephrolithiasis, so kidney stones. Dysgeusia, which just means like taste bad. And like that's actually one of the mechanisms by which it helps you like not eat as much, but it could be so bothersome that like the patient's not going to want to take it. Okay, who wants all their food to taste like really gross? It's like a metallic taste or something like that. I don't know how long it lasts. I've never taken topiramate. I don't know if it just tastes bad like as you're taking the med and like a few minutes after, or if like stuff tastes bad all the time. um Contraindications, another interesting point here. They don't have a contraindication for cardiovascular disease as they do for phentermine. Um, so, but I would still like, I would still like, I would take those contraindications of cardiovascular disease stuff that we talked about on the last obesity episode for phentermine. I would take those into consideration, even though they've decided not to put them on this medication. Okay, so like I consider the contraindications to both meds individually because I'm going to prescribe them individually anyway, right? So, but what are contraindications? Even though cardiovascular disease is not listed, hyperthyroidism, glaucoma, agitation, history of drug abuse, which I'm not actually concerned about because I don't think drug abusers are going to abuse phentermine. But if you're trying to get them to the GLP-1 because you don't think the phentermine is going to work for whatever reason, you can use that as an excuse to skip the med, right? Because if somebody has a contraindication, it means you can say, hey, I can't give them this med. And then you can skip it in the formulary to get the insurance coverage for the thing that you're trying to get. At the same time, if I think I really want someone to take phentermine, I'm not going to be concerned about their history of drug abuse and giving it. So I'm going to give it anyway. All right. So you can kind of use that either way you want. Right. So also use of MAOI within 14 days. So those are all things we talked about. Those are all related to phentermine. Of course, hypersensitivity, that's like an allergic reaction. That's a contraindication on every med, but you don't know they have it until after they take the medication. Pregnancy, of course, breastfeeding, of course. And then topiramate with kidney functioning, we have to look out for. So if our GFR, or glomerular filtration rate, that's how we measure kidney function, is less than 50, we have to reduce the dose. And if our GFR is less than 30, we cannot use the topiramate, right? We can still use phentermine, but we can't use the combo product Qsymia or topiramate on its own. All right, so um, you may be wondering, let's just kind of overall say, when would I give a patient phentermine topiramate? Like I said, it 10% weight loss. This is a pretty good med. I think I have used this. I would split it. I like the splitting in prescribing individually and titrating them one at a time. Do phentermine, add topiramate. This is a medication you often have to go through anyway to get to GLP-1s. It's a medication that works better than everything else other than GLP-1s. So if those don't work, or if we use GLP-1s and we lost a lot of weight, and now we want to keep the weight off, but we don't want to go back to a GLP-1, this is an option. If we're having insurance coverage issues, this is an option, especially if we're giving the two generic products separately. So I actually do really like this medication. But of course, there's all the caveats we talked about and all the things we need to be worried about with the risk and so forth. So yeah, I'm a fan of this one. I think people don't think about it that much because the GLP-1s are so popular, but 10% weight loss is substantial. All right, so let's talk about another FDA-approved medication. So this would be a Contrave, otherwise known as Naltrexone and Bupropion combined. Came out in 2014. This one is not generic yet, and this is another one that I'm never going to give someone Contrave. I'm going to split it. All right, same deal. All right. So mechanism of action, how does this thing help with weight loss, right? So we've got naltrexone in there and we got bupropion in there. So naltrexone is a medication we use for alcohol, to help people drink less. It is a very underused medication. I hear this all the time. Like, it's some ridiculous percentage of patients that have alcohol abuse are not even offered treatment, and pretty much most of them should be offered naltrexone if they want to stop drinking and they want to take something. You should offer them naltrexone. It helps decrease cravings for alcohol. Well, apparently it also helps decrease cravings for food. So it's a mu opioid receptor antagonist. It's also used for opioid abuse, though the other options for opioids are way better. I would probably never use naltrexone for that. Um, I would use buprenorphine, and one of the combo pills that use one of the formulations that contains buprenorphine is what I would use for opioids, as my top choice. And then I would use methadone also before I would use naltrexone. So I don't think naltrexone is very impressive for this, but it is a mu opioid receptor antagonist. So, but it helps with alcohol cravings. It also helps for food cravings, and it helps with emotional eating. So that's the other thing I think about. It's like you have to think about like what's kind of the mechanism behind this patient's eating, right? If they're a night eater, topiramate's a good option. Maybe you only use topiramate, right? They're just a night eater, right? That's the problem. Topiramate, good for night eating, okay? If we're trying to suppress appetite, we have lots of options. Phentermine's an option, okay, for that, right? And then here, where we've got naltrexone, are they emotional eaters, right? They get stressed or whatever, and then they eat in those situations. Naltrexone, good for that, right? So it's also helpful to kind of know like how do these meds work and what kind of eating, right? If they're a binge eater, lisdexamfetamine, Vyvanse, that's what I would consider, right? So think about like why they're not able to eat less. Because ultimately, the reason why someone is obese is because they are consuming too much food. That is the primary reason. And the way they're going to lose weight is to eat less. Okay. And so, if they're a lot of people, they hold their diet really, really well. And then they have this like emotional eating session, or the night eating is something that people will do like in their sleep, right? They eat, they're sleepwalking, right? And a lot of people that sleepwalk will eat while they're sleepwalking. Sleepwalking is actually not as uncommon as you may think. A lot of people do it, and they do all kinds of stuff on it. And there's meds like Ambien and Zolpidem that actually cause this to happen, right? And so, like, there's a lot of meds that cause amnesia, right? So you don't remember doing something, and you may not remember getting up after you went to bed, going in the kitchen and eating a bunch of cereal, and then going back to bed. And then you see the evidence of what you did in the morning. The brain is a sneaky thing. You may be able to control your eating really, really well, and then it'll be like, you know what? Screw you. I'm going to eat while you're asleep. And this totally happens. People have sex in their sleep. They eat in. I mean, there are cases of people like essentially sexually assaulting their partner while they're sleeping, and so it's like, can you really say that they've committed some sort of malicious act? They were asleep when it happened. That happens. Okay, now that may be a convenient excuse for someone as well, but it does happen. People have sex in their sleep. They drive in their sleep. They walk in their sleep. They eat in their sleep. They do all kinds of things. Okay, so topiramate might be good for that patient, right? So, and naltrexone, the emotional eaters, all right? So that's why it's important to kind of know that, all right? So that's what naltrexone does. What about bupropion? Well, bupropion is in many ways similar to our stimulants, right? It is a amphetamine derivative. It kind of works like our ADHD meds, so kind of like the lisdexamfetamine Vyvanse for binge eating. It kind of like the phentermine, right? It increases norepinephrine. It's a norepinephrine dopamine reuptake inhibitor, okay, and that has appetite suppression. I like using bupropion first line for a lot of my depressed and anxious patients. Go back to my bupropion episode. It's actually one of my most popular episodes. People are fans of bupropion. They want to know about bupropion. All right. Um, I I am not as big of a fan of the serotonergic meds. I think they do work well in a lot of people. Remember that a lot of this is placebo that we're treating for depression, anxiety. And so just giving the patient anything is going to have the same effect as something else. Bupropion tends to have less adverse effects than phentermine. And or not phentermine, sorry, the serotonergic meds like Zoloft. So like I will often try it first. Not everyone tolerates it, but you don't get the sexual side effects from it. In fact, it can improve that in some patients. I mean, it's often used added on. I'm not a huge fan of an add-on to an SSRI with bupropion to help with sexual side effects. Why not just give bupropion by itself? It's equally effective for depression anyway. Why am I giving both? Um, why not just give bupropion first? I do often use them together, but not for that purpose. Um, so bupropion also it's an antidepressant. So if you've got a patient that's depressed, it's another good reason to use it. So and in the depressed patient, the serotonergic meds can actually cause weight gain. So if we're worried about that, another good reason for bupropion, I might switch them to bupropion to help with that weight gain they had associated with the SSRI. I probably didn't put them on the SSRI in the first place because I usually start people on bupropion. But there are some patients where I think, oh, an SSRI is probably better for them. Let's try that first. Oh, that didn't work out. Okay, well, let's go with the bupropion then. All right. So bupropion is an appetite suppressant. So if anything, it should decrease weight, unlike almost every other psych med that increases it. So we talked about the POMC, the pro-opiomelanocortin. Phentermine acts on that, and that helps with appetite suppression. So both bupropion and naltrexone both act on POMC. So we've got this mu opioid receptor antagonist helping with emotional eating. We've got this norepinephrine dopamine reuptake inhibitor, but mostly we're looking at the norepinephrine reuptake inhibition there. The dopamine is not really affecting our weight, helping with appetite suppressant, and then we're acting on POMC. So like you would think like this should be a pretty darn good med. I mean, it's got two different meds, they work in different ways and synergistically on another receptor. That's fantastic. Well, unfortunately, it does not work that well. All right. Average weight loss is only 5%. So not a great option. Now, in the studies, there are some patients, like even though the average is 5%, some patients may respond better than others. All right. So compared to placebo, 48% of folks versus 16% of folks. So 48% of folks taking this med versus 16% on placebo will lose 5% of their body weight. So about half of patients will lose 5%. That makes sense. The average weight loss is 5%. So 50% of people lose 5% or more. Okay. That's at least 5%. So you're going to get some weight loss more than likely. Now, if we're looking at a 10% weight loss, which is like our goal in many cases, right? When we talked about like health benefits as far as like diabetes risk, sleep apnea, all that stuff, 10% body weight loss is that is the key. It may not be what the patient wants to look like, but it's what's helping with their metabolic disorders. All right. So 25% of patients versus 7% on placebo lost 10% or more with the naltrexone bupropion Contrave combo. So for a smaller percent of people, they actually do lose a decent amount of weight on this medication. Overall, this is probably one of our least effective medications. It's not the least effective. We haven't talked about those yet, but it is on the lower side. Phentermine is like 7-8%. The phentermine topiramate is 10%, and this is 5%. So this is not a great one. It's FDA approved for chronic weight loss, 18 and up. So kids can't use this one. Okay. How is it dosed? It's dosed funky, kind of like our last one was, the Qsymia. You have to, every week you change it. Week 1, it's an 890, so 8 milligrams of bupropion, 90 milligrams, 8 milligrams of naltrexone, 90 milligrams of bupropion in the morning, which is a nothing dose of both. Remember, naltrexone typically starts at 25 milligrams when we use it for alcohol reduction of alcohol intake, and bupropion starts at 150, and you can start 150 to 300 for depression. So we're starting 90 of that. Week 2, you go to the same pill, 8 and 90, but you dose it twice a day. And then week 3, we do a 16 180 in the morning and 890 in the PM. And then week 4, we do a 16 180 twice a day. So basically, it's a slow titration every week, and you end up with what ends up being 32 milligrams of naltrexone and 360 milligrams of bupropion. Those are slightly higher than the normal doses of both of those meds. But here's another downside. You're dosing it twice a day. Why are you doing that? Because for some ridiculous reason, they decided to use the bupropion SR formulation, the sustained release, instead of the bupropion XR extended release once daily formulation. Once again, they've given you funky numbers that don't add up to normal doses that we had of these meds before, and we've decided to use SR, which, I don't know why we're doing this. And so once again, I'm going to prescribe these separately every single time. When would I ever prescribe the Qsymia Phentermine Topiramate ER combo pill? Never. Never. I can't think of any situation in which I would do this. I would always prescribe them separately. Unless for whatever reason their insurance would not pay for them separately, and I don't know why not, because they are cheap, I would prescribe them separately. It's just advantageous in every way. Same with naltrexone and bupropion. It's advantageous in every way to prescribe them separately. There is no advantage to giving someone Contrave. And we'll talk about all the advantages here, right? So advantages. I'm only dosing it once a day. That's great. I'm only I can also, and why do I want bupropion twice a day? It interferes with sleep. I don't want to dose later in the day. I would prefer to have it earlier, and we're avoiding that. And are they going to remember to take it twice a day? People don't remember to take things twice a day. Better to take it once a day. Okay. The only hiccup here may be that the insurance company doesn't want to pay for. Sorry, it's not bupropion XR. It's XL. I made a mistake there. I was just like, that doesn't sound right. I don't know what that L stands for. Is that extended release instead of, I don't know. Sometimes they want to use XR. Sometimes they want to use XL just to stand out. It looks like extra large, but extra long maybe? How about if it's extra long, not extended release? It's extra. I've never even thought about that. Maybe XL means extra long. It may be difficult to get bupropion XL covered on its own for if you're just giving it for weight loss, and so that may be a reason to be forced into Contrave. But does this patient have a depression? Do they have anxiety? Good chance they do, because there's massive comorbidities between obesity and mental health symptoms. So you could just give them the bupropion for that and get it covered that way. Okay, so that you can give it separately. All right, so you got to play the game. So how do we dose this separately? So naltrexone, usually we're dosing 50 actually. I think I said 25 before, but normally we're dosing 50 for alcohol. And with bupropion, we're dosing between 150 and 450, and more often than not, I'm doing 300. So the highest dose of Contrave is 32 milligrams of naltrexone, so that's lower than the 50, and then 360 of bupropion, which is higher than the 300 I normally do, but lower than the 450, which is the max dose for the medication. So what I'm probably going to do is dose naltrexone 25 to 50 in the morning, and bupropion XL 150 to 450 in the morning, and probably more like 300. So what I'd probably do is, and the thing is, when am I even using this med, right? Why do I even want to use this med? Well, it would be because I'm not typically going to use this medication for weight loss by itself. It's just not that effective. However, if they have another reason to take naltrexone or another reason to take bupropion, those would be good reasons to use this for weight loss. Okay, so say they've got depression, say they've got anxiety, say they've got alcohol, um, their excess alcohol intake, alcohol use disorder, right? Say they smoke, right? Remember, bupropion SR, Zyban is used to help with, and not just smoking, it's nicotine. So are they a dipper? Are they a snuffer? Are they a vapor of nicotine, right? Any kind of, don't just think about smoking. Are they using those Zen packets? Any kind of nicotine, if they're wanting to like get rid of that, bupropion actually works fairly well. We haven't talked about this yet. Bupropion actually works really pretty well. Like I don't see a lot of total quits, but typically less intake. So if you got a patient that is a nicotine user, an alcohol abuser, a depressed patient, hey, you should be using these medications anyway, and they're overweight. Whoa, these are the ones you should have picked for those disorders, right? So oftentimes what will happen is, as a psychiatrist, I use bupropion all the time. So I've already got the patient on bupropion XL. They're already on it, and they're probably on 300. I usually give them 150 for, I say 3 to 7 days. And then 1 week is easier to remember, but like I always say, like, if you're tolerating it after 3 days, you'll tolerate an increase just as easily as you would 4 days later. So if you're the kind of person that's like wants to get up to the regular dose as quickly as possible, you can do that on day 3. If you're the kind of person that's more anxious about it, you could wait a week or two. Oftentimes they would come back and see me, and I'm like, no, you can go up. They're like, I didn't know, I was anxious to go up. I was like, we already discussed this. Everything sounds fine. Go ahead and go up now. Right. So I probably already got the patient on bupropion 300 because I'm treating something else. And then the weight becomes an issue. And I'm like, well, we're already on bupropion. Let's just add naltrexone. Let's just throw that on there. And do you drink more than you want to? A lot of people do. All right. So, hey, another reason to use naltrexone. So this is when I'm using this medication. I'm using it because I use both of these two medications individually quite frequently. And so if I can also like help them with their weight, this is actually the very first medication I ever used to treat weight loss when I started treating weight loss 10 years ago. Um, this came out in 2014. No one talked about it. I graduated residency in 2016. I'd never heard of Contrave. No one talked about it. It wasn't taught in our residency program. Nobody cared about this. I ran across it, I think, in a Wikipedia. I think I was reading through Wikipedia. I was like reading about bupropion in Wikipedia, and it mentioned this. And I was like, what? Never heard of Contrave. Or you're looking up and up to date and you're seeing, bupropion. What is this bupropion naltrexone thing? And you click on it and you're like, oh, interesting. So that's kind of how I found it. And I was like, why is no one doing this? And so I treated several patients with these two medications individually because I was like, well, being in an overseas military base, we don't have Contrave anyway, but we do have naltrexone and we do have bupropion. So I would prescribe those separately. And I would see about, I would say 5%, sometimes up to 8% weight loss. And so two birds, one stone. That's why I'm using this. Remember, Qsymia, Phentermine, that's you. If I'm just treating obesity, that's probably the one I'm going to use first. Who am I not using it in? There's not a lot of people I'm not using it in because it's really the first step if you're going to treat obesity with medication. If somebody has one of the contraindications to it, or they're like a really anxious patient, or really agitated patient, those would be people that maybe you could say, hey, they've got a contraindication, let's skip it. Qsymia, I think, or the combo with Topiramate is a good option. This one is not as good of an option, naltrexone, bupropion, but like I said before, I've given people all these. I've given people naltrexone, bupropion, phentermine, topiramate, all 4 meds prescribed separately. And the good news is, when you do that and it doesn't work, you can then move on to a GLP-1. Now, I may leave them on one of those meds. Maybe bupropion was treating their mood. Maybe naltrexone was treating their alcohol disorder. Maybe, phentermine was helping with their ADHD symptoms. Like maybe topiramate's treating their migraines. So the patient's got migraine and we need to prophylaxis on that. So like, maybe I've got them on a lot of these meds at the same time. You can combine all these. There's no interactions between these meds, right? each med has its own contraindications, and I haven't discussed the ones for these, but like you have to look at them individually. There is nothing that I'm worried about if I'm using these meds all at the same time. There's no there's no um, there's no drug interactions between these meds. So feel free to use them all if they tolerate them and they can use them all safely. Use them all at the same time. Why not? Yeah, I mean they all kind of work on the brain in different ways. So I mean bupropion, phentermine. If you've got some cardiovascular stuff going on, they may exacerbate each other. So not really a drug interaction, but a little bit. So that one, maybe I don't want to use bupropion and phentermine together, but like say I'm using one of them and there's been no effect on vital signs. Well, no reason not to add the other one. I'll keep an eye on them. But if one of them's kind of raised it a little bit, but like not to a point where I'm that concerned, I might be concerned about adding something else that also increases norepinephrine that may raise it further. Okay, so that would be the one the one that I would be concerned about. But like I said, if it doesn't affect it, no reason why you can't do it. All right. So, and then like I said, if you're not getting the weight loss that you're looking for, peel them off. Right. Don't keep them. Discontinue them. This didn't work. But hey, if like I said, if one of those meds or more than one of those meds is treating some other condition and it's really helping them with that, not with the weight loss, but with something else, keep that one. Right. Get rid of the ones that didn't add any benefit. Okay. So this is where you can get real fun here with your obesity treatment, like that you patients, and I complain about this, but like all these quacks out there, they complain on behalf of patients of we're not personalizing medicine. We need to check these BS labs that don't do anything. I need to give you some BS supplement that doesn't do anything. I'm personalizing medicine, and it's like no, we can actually personalize medicine with proven treatments, not using a bunch of BS supplements and BS lab tests and like unproven therapies that don't do anything. We can combine all these different obesity treatments and time them and select the one that we think will work best for like what kind of problem is causing them to eat too much, right? And we can do the customization in that way, right? So we can customize these treatments for patients, right? um, and we can actually use proven therapies. All right. So that's kind of how this fits into the algorithm for me. All right. So let's talk about the issues with bupropion and naltrexone. All right. So warnings and precautions. Nausea can happen. Um, but it tends to get better. Maybe you stay on a lower dose a little bit longer and titrate up slowly to help with that issue. Heart rate can increase. And remember, bupropion is actually causes this more than phentermine. Everyone worries about it with phentermine, but bupropion is actually more likely. So heart rate and blood pressure can increase with the bupropion. Of course, we have that black box warning on suicidal ideation. So that's something that we always have to keep in the back of our mind. Hepatotoxicity, so liver damage, naltrexone, really low risk of that, but something we need to keep in mind. Probably should check the liver enzymes. And so those are warnings and precautions. So those are things where it's like, hey, let's keep an eye on this, but we can still do it. Now let's talk about the contraindications. So there's a lot of them. These are reasons why we can't use these. Now remember, these reasons are not necessarily why we can't use one or the other. We can't use the combo pill because the contraindication might be one for one med or the other, and now we can't use the combo at all. Another reason to split it, because we could still use one of them. Okay. So what are the contraindications? Uncontrolled hypertension. This is for bupropion. Okay. Uncontrolled hypertension. History of seizure disorder, bulimia or anorexia. Now, of course, we're not giving patients weight loss meds for bulimia and anorexia anyway, but that increases risk of seizure. So bupropion has increased seizure, lowers the seizure threshold. So anything that will increase the risk of seizures is a reason not to take bupropion. All right. If you're taking other bupropion or naltrexone containing products, so if they're already on bupropion, don't give them Contrave, right? If they're already on naltrexone, don't give them Contrave, right? So that makes sense, right? Another reason not to give the combo pill, because like we prescribe them separately. There's no other medication that contains bupropion or that contains naltrexone. They're not available in any combo products. I mean, maybe you're giving them Zyban for smoking, but like that is bupropion. You're not going to add bupropion to bupropion. They're already on bupropion, right? But someone may not think not to add Contrave to Zyban because they don't think, oh wait, Zyban is bupropion and Contrave contains bupropion. If we just prescribe bupropion by itself, we don't run into this issue. All right, so don't double up on them. If they have a chronic opioid use disorder, right, or they're using chronic opioids, or they're going to have a procedure or a surgery where they will be taking an opioid, don't give them naltrexone because it basically makes the opioid not work. All right. So I've seen this before, right? So if you're giving this and you know your patient's going to have a surgery, say, hey, you probably don't want to take this because the opioid they give you will not be terribly effective. All right. So this is a mu opioid receptor antagonist. It's going to block that. The opioid's not going to be effective. And then you're going to be in pain. All right. And if you're taking opioids and you need them and they're prescribed, you can't take naltrexone. All right. They won't work. And then they may take a lot more of those opiates. They may get them off the street. And the problem is because the naltrexone has made them not effective. Now you've got them hooked on some street drug. So be careful about that. Anything else that lowers the seizure threshold, right? Obviously, having seizure disorder or an eating disorder lowers the seizure threshold, but also abrupt discontinuation of alcohol or benzodiazepines or barbiturates, right? Or they're on anti-seizure meds, right? I mean, they're probably on these anti-seizure meds for a reason. This person should probably not be taking bupropion, right? And of course, we want them to cut back. If they are a heavy alcohol user, and you're going to give and for some reason they just stop all of a sudden, that increases their seizure risk or lowers their seizure threshold. And so bupropion would be risky because that would increase the risk of seizure further. All right. Use, once again, we have the use within 14 days of an MAOI. This is a bupropion risk because it increases monoamines, and increasing monoamines increases the risk of hypertension in this case, not serotonin syndrome. It would be risk for hypertension, malignant hypertension. So be careful with that. Pregnancy, once again, we don't use any of these meds in pregnant patients. And decompensated cirrhosis, if you have a patient so cirrhosis by itself, not a contraindication to naltrexone. In fact, the reason why they have cirrhosis is probably because they drink too much. And if they're still drinking, you should probably be giving them naltrexone. Okay. So a lot of people think, oh, I don't want to give this to anyone with liver problems. It's like, but if they're drinking and that's making their liver problem worse, naltrexone can actually help with that. However, it's when you get to the point of decompensated cirrhosis that naltrexone becomes the risk. It's when LFTs are going over like 5 times the normal value, right? So, and often with cirrhosis, LFTs are actually lower. So it's decompensated cirrhosis, right? But this is, probably more specialists are going to be dealing with this type of issue. You want to be like someone who's specialized in alcohol treatment and so forth. But just kind of be aware that naltrexone can be used with liver impairment, but it's in the kind of patient that like you're not going to be giving naltrexone. I mean, decompensated cirrhosis, am I really treating obesity in this patient to begin with? No. And so like, when does this ever even come up that I'm not going to use this for, this patient is extremely sick, I'm not going to use it anyway, right? This is a person with jaundice, their child pew is like a C, maybe a B, but like a C, even if it's an A, you're still using the naltrexone. Okay. So, but in a patient that's sick, I might be using naltrexone for alcohol use disorder, but do I want to take the chance on using it for weight loss? How concerned am I about weight loss in a patient that has severe liver impairment to begin with? It's probably one of my lower concerns. So that is something to keep in mind. All right. So we had a nice long episode today, and we dug in deep on 2 of our remaining FDA approved medications, brand name Qsymia and Contrave. And I hope you enjoyed that. I'm going to go ahead and go through all the other remaining meds other than GLP-1s on the next episode. There's a couple of FDA approved options left slash FDA cleared because one's a device, even though you swallow it. And then we've got some off-label stuff that you could consider in certain situations. And so that's what we're going to talk about next time. And then, I mean, then it's what everyone's been waiting for. I'm probably going to have like 8, 9 episodes on GLP-1s, because there's just so much to know about them. But we got to finish up the extraneous meds first. So I want to thank you so much for joining me today, and I'll see you next time.